Health First Aid. I'm Denise Ellsbury, and this month our guest is Terry Ciszek, who is the Director of Social Services and Case Management. I think I got that right.
Yes, you
at
did.
Linden Oaks Behavioral Health. And Terry is here to tell us a little bit more about seasonal affective disorder. So welcome, Terry. Thank you for being here.
Thank you, Denise. Thank you for having me. I'm glad to be here.
Great. So maybe before we start talking about seasonal affective disorder,
Sure.
Tell us a little bit more about your role at Linden Oaks. What do you do at the hospital?
I work both with the inpatient and the outpatient programs.
Okay.
And I do mostly staff supervision. I also help with program development. And so I do a lot of reviewing of care plans of all of our patients, both inpatient and outpatient, and give feedback to my clinical teams on how to make that as effective as possible.
And you work with all the different clinical teams, is that what you're saying?
I do. I help oversee, we've got 4 outpatient sites.
Right.
And then we also have, obviously, our inpatient, we have a 108-bed inpatient psychiatric hospital. So I help the clinicians that work both inpatient and outpatient.
And you are a licensed clinical social worker?
I am. I've been a licensed clinical social worker since 1980, so I've been around a while. And I also have a senior level addiction certificate in the state of Illinois. So I actually began working in behavioral health in the addictions field, and then broadened to both addictions and mental health.
So when you're working with clinical staff or kind of looking at the program, what kinds of things are you working with them on?
Yeah, obviously we want to first and foremost make sure that we're offering evidence-based treatment.
Okay.
There's a lot of different types of treatment and care out there, but unless it's really been researched well and been able to be repeated time and time again to show efficiency. So we want to make sure that the clinical models all the teams are using are evidence-based. And then the other part of what we do, that's kind of the science part. There's also an art, I think, to therapy. And that art piece is just having really good patient experience skills. So, how would you want to treat your family member if they came in? That kind of a mindset. So
it's that relationship piece.
It really is. The foundation of therapy is the therapeutic relationship. And so early on, I think, particularly in the addictions field, we felt like confrontation was like the most important kind of clinical tool. If you weren't ready to stop using, the confrontation would be used. We have found that was not effective, and that we really have to meet people where they're at. And so that therapeutic relationship built on mutual trust and more of a sense of partnership really is the best way to go in therapy.
So as you were talking, I was thinking, so if I were someone who was looking, for a counselor or some kind of service,
yes,
kind of thinking about both of those pieces, right? That I would want my clinician, my therapist, counselor to be practicing evidence-based models.
Evidence-based treatment, correct.
And that it would also be reasonable for me to expect that I was having a positive relationship experience with them as well.
Absolutely. We kind of know when we're a match for people, and I think in some of that is just kind of instinctive. And so sometimes people go to a therapist and they may have been recommended for that person because they've been told that they were very good. Well, maybe they're not very good for me because the match just isn't there. And so how one experiences the therapeutic relationship begins to build a sense of trust, I think really is the cornerstone. Once that is established, I think lots of really good things can happen in therapy.
All right. So in terms of that evidence-based piece, that is probably something then that you're having to kind of always be keeping on top of and keeping tabs of, because new information's coming out all the time.
New information all the time, and lots of new things are being offered, but again, they've not been repeated time and time again under a good controlled research study. And so whatever might be the latest thing coming through the pipeline, we have to be cautious of that until we can really determine it and read the research, look into it more further, and then maybe ourselves. We've done some little bit of research ourselves. We're not really a teaching hospital, and so we haven't done that to a great extent. But you're absolutely right. Trying to stay on top of the research is an important thing for us.
And is that something then that you have the responsibility for doing, is kind of reviewing new information that comes out?
I have the responsibility to review that, and I also have the responsibility to attend many like continuing education kinds of workshops and in-services, so I can take in information and then maybe go back and research it. If the presenter doesn't offer as much information as I would like, then I go back and I do the research too.
And then if you get learn about some new models of treatment, and there are things that you want to incorporate into treatment at the hospital, how does that happen?
It happens a couple of ways. I may myself then develop a PowerPoint or develop a training session around that, or I might elicit help from a colleague who might have an interest in that area. And so we have a wide range of very high quality staff at Linden Oaks. We're very, very fortunate. And so lots of people have many interests in many different things. And so it's really a matter of establishing a good training sessions and then repeating that throughout both inpatient and outpatient services, so everyone is really up to snuff on the most recent research.
I've been at Linden Oaks not quite 2 years at this point, and one of the things I've really been impressed by is, how well people know sort of the treatment models that they're following, and that they also seem very enthusiastic and passionate about the effectiveness of those treatment models.
Absolutely.
And I think that really comes through then in their being able to be helpful to clients and patients that are there.
Absolutely. The word passion is absolutely correct. I think people really just have a lot of spirit and passion around good quality care and seeing day in and day out the improvements that their patients are making. When I work with the inpatient staff, sometimes the length of stay inpatient might be relatively short. But then they step down to an outpatient level of care where they might be with us 4 to 6 weeks. I'm constantly being asked by the inpatient staff, hey, how is so-and-so doing? Because that sense of connectedness happens even in a short length of stay. And so the passion and the overall caring for the patients really does come through with the staff.
All right. So you mentioned that you've been a social worker since the 80s,
yes, right?
And how long have you been with Linden Oaks?
I've been with Linden Oaks just a little over 10 years. It was 10 years in August, and so I've been very, very happy there. I was offered a position to come to Linden Oaks to open up our first off-site outpatient program in Plainfield.
Okay.
And that we're very fortunate. That was a very good success. And so as my time at Linden Oaks remained, they offered me to oversee all of outpatient. And so since then, I've been both helping start up and open some outpatient programs at other sites, but then also helping the inpatient staff as well.
Okay. So prior to you being there was just the inpatient hospital.
There was the inpatient hospital and outpatient services in the same building as the inpatient program. But we outgrew that as outpatient began to grow. And as it began to grow, we saw that there were certain geographical areas close to us that had some real needs. And so we opened up a site in Plainfield. We opened up a site in St. Charles, and then as we outgrew our place in Naperville, we opened up the larger Mill Street site in Naperville. And then after Edward and Elmhurst combined, we began, they already had a behavioral health service at Elmhurst, and just this summer, we moved those services to a new site in Hinsdale. And so,
awesome.
So it's very exciting.
It is. So when we come back from our break, I'd really like to talk about seasonal affective disorder.
Absolutely.
So join us when we get back from the break to hear more from Terry about seasonal affective disorder.
Their support changed my life.
They were like family.
My voice is now heard.
A home for every animal.
My future is bright because they cared.
This is our home now. Thank you to the 1,200 nonprofits that serve Cass and Clay counties every day.
Welcome back to Mental Health First Aid. I'm Denise Ellsbury, and we've been talking with Terry Ciszek from Linden Oaks Behavioral Health, hearing about what his role is at the hospital. But I really invited him here today because I wanted to learn more about seasonal affective disorder, which is something that we do talk about in Mental Health First Aid. So maybe we can just start out with, what is seasonal affective disorder?
Absolutely. Seasonal affective disorder has been around for as long as human history.
Okay.
There's been some early writings as early as the 4th century noticing that the change in seasons have an impact on people's mood and activity.
Okay.
But not until 1984, a psychiatrist by the name of Dr. Rosenfeld came through. He actually lived in Florida, moved to the north, and he noticed that for himself, as the seasons changed, he became more depressed. And he was already attached to the National Institute of Mental Health.
Okay.
And so he and his colleagues began to study whether or not seasonal change, its greatest impact has to do with light, since as the seasons change in the fall, there's less daylight. And so his studies began to show that, and studies began to replicate themselves to say, yes, there really is a connection between people suffering from depression from a seasonal standpoint and sunlight.
Okay.
And so seasonal affective disorder had been identified by the American Psychiatric Association starting in 2005 as its own diagnosis.
So prior to 2005, it wasn't like officially recognized
That's right.
as something, as an illness in and of itself.
That's correct.
Okay.
So that began in 2005, and then in the last several years, there's been a recognition, and there's been shifting in the American Psychiatric Association, where now seasonal affective disorder falls under major depressive disorder of a subtype, a particular kind. And so the actual title is Major Depressive Disorder with Seasonal Patterns.
Oh, okay.
And so
but it gets referred to all the time as seasonal affective disorder.
The colloquial term that everybody knows about it is SAD. Exactly,
okay.
yeah.
But okay, wait.
So,
Major depressive disorder with seasonal patterns.
Yeah, the new Diagnostic and Statistical Manual that the American Psychiatric Association puts out that identifies all the diagnosis and gives all the disclaimers for that. Shows it under major depressive disorder, not its own separate diagnosis now. But like you said, everyone still recognizes it as SAD.
Okay.
Yeah.
So what are maybe some common signs and symptoms of SAD?
Well, and since it falls under major depression, as we all know, major depression shows itself with intensity of sadness or depressed mood, a sense of worthlessness, low self-esteem, difficulty with sleep, difficult with appetite, fatigue, poor concentration, and then just really a less ability to function in our normal either school, social, or work life. And that can even lead to, if the worthlessness or emptiness becomes more severe, suicidal ideation and suicidal attempts. So to meet criteria for just major depression, 5 of those things have to be true.
Okay.
But when you come to seasonal affective disorder, there are some particular things that have to be true. The first one is that the depressive episode begins to show itself in the fall or the winter as that particular seasonal change happens. And in order to meet the criteria, it has to happen 2 years in a row. So 2 consecutive years where you were doing fine in the summer, fall or early winter comes along, and you notice more depressive symptoms that seem to be connected to seasonal change.
And it has to be like to the extent that you mentioned for depression kind of thing.
It can.
Okay.
So the things more likely to be seen in SAD are weight gain. In major depression, it could be weight gain or weight loss.
Okay.
But with SAD, it's more often weight gain.
Okay.
When it comes to major depression with sleep, it could be more sleep or less sleep. It's usually more sleep with seasonal affective disorder. There's also cravings for carbohydrates and sugars, and so that usually leads to a weight gain of at least about 5% of your body mass.
Oh, okay.
So some of those things are kind of unique to the seasonal pattern that SAD really offers.
Okay. All right.
Oh, and one more thing, I'm sorry. To have a diagnosis of this, then it spontaneously remits in the spring.
Okay, without, even
without-
if you didn't get any kind of treatment or anything?
At all. Come the spring, the depression lifts.
Okay.
And that's why it's so connected to the seasonal pattern change. So it starts in the fall and winter. It can last 3 to 6 months roughly. But come the spring, it just kind of automatically remits.
Okay.
And so that's kind of the key to seasonal affective disorder.
Okay. And one of the things we talk about in mental health first aid a lot is, right, a lot of times we might experience mild symptoms of
Yes.
things, but we're
Yes.
still able to go to work,
Right.
kind of take care of ourselves
Right.
and engage in relationships. But when we're looking at the diagnosis of this, we would say these are symptoms that are really starting to impact our ability to function in terms of work or school,
That's right.
take care of ourselves, and maybe even engage with other people, so that I'm like, I just don't want to go out,
Right.
or I don't want to do
Right.
anything anymore.
Right.
Okay.
I think with the seasonal changes we notice, with the colder temperatures, people usually stay home more. They might have less physical activity. And I don't know about you, but I'd much rather stay in bed with a good book and a cup of coffee if it's kind of dreary or outside.
Sure.
But it doesn't impact my functioning.
Right.
And so that's kind of commonly known as kind of the winter blues. That's another one of those common terms. But it's really kind of a milder seasonal affective disorder because it really doesn't affect our functioning. Yep.
So that piece about noticing when there have been more significant changes in functioning would be kind of our clue to say,
That's exactly right.
well, maybe somebody needs some additional support for this, or
Correct.
something like that.
That's exactly right.
All right,
Yep.
all right. Anything else that maybe are misconceptions about seasonal affective disorder?
I don't know about misconceptions, but maybe you should talk a little bit about risk factors.
Oh, that would be awesome.
That's okay. Women have this diagnosis 4 times more than men.
Okay.
And it seems to show itself usually in early adulthood, like around 20.
Okay.
It's very rarely seen in adolescence. And then as you get older, there's less frequency. So kind of the younger adult into early to middle adulthood is usually where we see this diagnosis.
And women more than men?
And women more than men.
Do they have a reason why?
I don't think, I haven't read anything that tells me why. They're just tracking the numbers, and that's what they say.
Okay.
The other thing is where you live.
Okay.
If we know, and we'll talk more about how much light has an impact on mood, but if you live along the parallel of the equator, or 30 degrees north or 30 degrees south of the equator, this is not found.
Okay.
And the farther you get north, and so Ottawa in Canada, Ottawa City, has a 7% rate of SAD in their population. Alaska has about 9%.
Okay.
And so the farther north where the light is even less frequent, during the winter months, they seem to have much higher rates.
Okay.
Yeah.
Excellent. So we started to talk a little bit about light, and we want to hear about this contraption right here. So when we come back, let's talk about treatment of
Sure.
seasonal affective disorder.
Sounds
so
good.
join us after the break to hear more about what we can do to help other people or help ourselves.
Their support changed my life.
They were like family.
My voice is now heard.
A home for every animal.
My future is bright because they cared.
This is our home now.
Thank you to the 1,200 nonprofits that serve Cass and Clay counties every day.
Welcome back to Mental Health First Aid. We've been talking with Terry Ciszek and learning more about seasonal affective disorder, or let's see, the official title is Major Depressive Disorder with Seasonal Patterns.
Very
I'm going to
good.
practice
You've got
that.
it.
So we finished off talking kind of about risk factors, but now we want to hear about what somebody can do about it, or what are the
Absolutely.
treatments.
Right.
And I know you brought something here.
I did.
So what
I
are
did.
some of the treatments for seasonal affective disorder?
We'll go through these in a little bit more detail, but the three major treatments is light or phototherapy, and then possible use of antidepressant medication,
Okay.
and then psychotherapy.
Okay.
There's two primary psychotherapies that have been evidence-based for seasonal affective disorder. One is cognitive behavioral therapy, and one is behavioral activation.
Okay.
But let's start with light therapy, since that is the first suggested treatment approach to use.
Like try that first.
Try that first.
Okay.
And the nice thing about light therapy is you can do it by yourself. You can buy, this is a light box that I will be talking more about, but light therapy is simply using this light box to mimic normal sunlight.
Okay.
And so the recommendation for a sunlight is this. The sun box should have a light that has 10,000 lux. Now, lux simply means it's a form of, or an amount of illumination that mimics skylight 40 minutes after sunrise.
Ooh, it's really specific.
It's very specific. And so you have to make sure your light box has that kind of light.
Are these, I mean, I know we have these at the hospital,
Yes.
but people can purchase these?
Purchase them right off the internet. And so the important thing is to make sure you get a 10,000 lux light, one that has ultraviolet filtering.
Okay.
But other than that, you can buy one for like $100, $150 online very simply.
Okay.
I think you just Google light therapy,
Okay.
and all the ads will pop up.
Okay.
The ideal way to use a light box is to do it first thing in the morning, and roughly for 30 minutes.
Okay.
And so this is about the right angle to use a light, and so people will have it close enough to them where they can read or eat breakfast or work on a computer. The light isn't going right into their eyes. You're not staring at the light, but light is entering your retina through this, much like sunlight would.
Okay, so it has something to do with the your vision.
It does, because I'm going to try to keep this very simple. Light comes into your retina, and there are photosensitive cells that send a message to your internal biological clock. That is just a bunch of neurons behind your eye, and that then sends a message to the pineal gland that secretes melatonin. Melatonin.
Complicated.
It's a little
isn't it?
complicated. Well, melatonin is really the hormone that generates for us, it's time to go to sleep. You know,
Okay.
people take melatonin supplements sometimes if they have sleep disorder difficulties.
Sure.
And so the circadian rhythm between daylight and nighttime is one of those 24-hour, circadian actually means around the day. So it simply is talking about, we all have different circadian rhythms that naturally happen in the body, but they're influenced by our environment. And sunlight is one of those. And so one of the reasons, or one of the ideas behind why people suffer from seasonal affective disorder is that they may be predisposed to the less sunlight that happens as the season changes.
Okay.
Changes their circadian rhythm, and if that's off, then more melatonin is generated, you become sleepier during the day, you're less functioning, gain weight, and all the symptoms we talked about earlier begin to happen.
It's fascinating, really, to think about how all of those things interplay within our bodies.
Absolutely.
Really fascinating.
It is.
Yeah. So this is kind of the first thing that is recommended, to try.
Correct. And then the second would be an antidepressant medication.
Okay.
Any selective serotonin reuptake inhibitor. And so many of those are, most people know what those are and how those work. And then thirdly is psychotherapy, particularly cognitive behavioral therapy, because the people's thinking then about I'm not functioning well, I'm not, I should be getting up and I'm not. All that negative, we talk about ANTs, automatic negative thoughts.
Okay.
And so we work our best to try to challenge what those are and help people begin to think differently. And behavioral activation, as we said earlier, is just recognizing we have to get active. We know that physical activity increases our serotonin levels, which then increases our positive mood. And so the more that people can get active, so the combination, I think, of light therapy, antidepressants, and psychotherapy really is a 1-2-3 combination that's been found to be very, very effective.
Okay. So I would imagine for some people, just the knowledge and identification of like, oh, that's what's going on for me,
right,
can be very, very helpful. I mean, you still need to do some of these other things,
right,
but just having that knowledge can be very helpful for people.
Just having it being understood that there's not something so uniquely wrong with me that I don't have to feel guilt or shame about this. This is a bona fide condition that has a very effective treatment model that we can use. Absolutely.
That in and of itself provides hope to people.
It certainly does. Yeah.
Just from the light itself, is there research that shows how many people really just that in and of itself is helpful for percentage-wise? Someone who's has that diagnosis?
Yes. They've done studies where they've just done light, just done drugs, and just done therapy, and then all of the different combinations. They have found that the most long-term effective is light and therapy.
Okay.
But medications, obviously, for some people, they find that also very, very helpful.
In terms of this, someone who might experience this at a more severe level might need all three of those things.
And some people are just leery of side effects of medication, so they want to try everything before medication has to be tried. So, but any combination has been found to be effective.
Okay. All right.
And then when you think about that, other things that we can just do normally and naturally during the winter, keep our curtains open.
Okay.
Trim our tree branches so more sunlight can come in.
Okay.
Even if it's cold, get outside a little bit to have
Take the dog for a walk.
Take a dog for a walk. Absolutely.
Go volunteer and find a dog someplace
there
to
you
take
go.
for a walk. Right?
So even getting outside sometimes in the winter is helpful. Just again that sunlight in the retina that we're not even that conscious of at all, but it's happening to kind of help our circadian rhythm stay stable.
Okay. So, I mean, you mentioned that behavioral activation.
Yes.
Can you talk just a little bit more about that?
Yeah, it's a very simple kind of theoretical model that says the more active we are in spite of what our thoughts and feelings are, that activity alone will both help us physically and mentally and emotionally, and it will activate some things in our brain that help us with a positive mood because of the increase in serotonin. So it's all about just do your best to get up or have a buddy help you get up and just get going. Because these are so debilitating kinds of illnesses because we just stay isolated, we stay alone, and we don't get active, and the more that happens, it just becomes a revolving door.
Right. So this has been really fascinating talking about this. Thank you so much for being here,
You're
Terry.
welcome.
It's great to learn about what you do and about seasonal affective disorder. Thank you for being with us on Mental Health First Aid. Until the next time, be well. Oh, I learned a lot today. That was awesome. Like I say, we kind of mention it really quickly in Mental Health First Aid, just as sort of like, here's one thing you might hear about, but now, and we're not really supposed to go really in depth, but I feel if somebody asks a question,
Now you got some
better information. It's funny because like on the slide where it mentions it, of course it says seasonal affective disorder, and it also says postpartum depression, but now I know the two different
There you
things
go.
to say,
There you
right?
go.
Perinatal mood and anxiety disorder
Right.
and major depressive disorder with